Hi, welcome to the Dr. Lam Show. I'm Dr. Carrie Lam, and today I have Dr. Sneha Gazi here with me. She's a physical therapist located in New York, but she also does telehealth PT in New York, New Jersey, and Maryland. But she deals a lot with decreasing body pain and helping people's quality of life. As she was a professional dancer and certified yoga teacher, her passion for movement led her to the work that she currently does. So, we are very glad to have her here today on our show as we're going to talk about not only seeing what would be the best advice if you have to go to surgery to not do that as the first choice, but also if you are interested in pelvic health and women's health, she can also teach us a little about that and chronic pain. So welcome, Dr. Sneha.
Thank you so much, Dr. Lam. It's a pleasure to be here.
Yeah, I see that you have a strong passion for helping people with chronic pain. Tell us how you came to incorporate this holistic background, Eastern and Western, into your practice.
Sure. So I am from the Indian culture. And so we have a lot of Eastern practices of healing. We do a lot of herbal medicines. And there's just a lot of stuff out there in our culture for naturopathic healing and natural healing. There's Ayurvedic treatments and tons of things that are outside of the Western kind of evidence-based, more so like researched approaches. And so growing up, I always was exposed to that. But of course, I am a doctor of physical therapy. I went through 7 years of school and dissected cadavers and completely understand and trust and work in the scope of Western medicine as a doctor in physical therapy. So I, in my practice, really combine a lot of those elements to really help my patients and meet them where they're at, because a lot of people's understanding of healing and wellness is very different. And there's not always one way or one path to recovery. Sometimes there's a lot of ways to incorporate holistic approaches. For example, a lot of my patients, I send them off to acupuncture, or I will send them off to other providers who I think could complement our services. And, I know that a lot of different, I have my own podcast and I talk about this and bring on guests who are, around the space of health and wellness as well. And so I really believe that different professions can provide so much more insight. And by working together, I think that we can actually serve our patients better in lots of ways. So that's kind of my background. And, I'm, like you said, I'm also a certified yoga teacher and I'm an Indian classical dancer. So a lot of my, training and understanding of movement comes through that as well, outside of my DPT. So I incorporate a lot of, I can't really separate my dancer self and my yoga self and my doctor self. It's really hard to do that as one can know. So it's really everything that I offer to my patients comes from all of those backgrounds and understanding all of those disciplines.
That's true. And that's what I love about integrative medicine, right? Integrative means not only Eastern, Western, but it's the tools that you can bring together from different specialties. Yeah, I definitely send my patients to physical therapy all the time, especially if they have musculoskeletal concerns or pelvic floor issues. Those PT is a great segue in helping patients structurally with exercises and things like that. So,
yeah. And also to go off of that, so
mhm.
many of what we say is like Eastern medicine has been evidence-based now in Western medicine too, right? Gua sha techniques, acupuncture, cupping. We see that now in the Western medicine as, medical acupuncture and, IASTM or instrumental assisted soft tissue manipulations. And so a lot of these things are already out there. People are just understanding, like, just because there's maybe not RCTs and systematic reviews, like, there's so much. People have been using a lot of techniques for centuries. So at the end of the day, it's really the technique. And then how does that apply to the patient? And does the patient trust that technique and understand that how it can be beneficial? And so that's where I think communicating with the patient is more important than kind of categorizing it as Eastern or Western or anything like that.
Yeah, definitely. I love that definition. So, what are some very common things that you see, and some advice you would like to give in general?
Yeah, so like you said, I specialize in pelvic health. I do treat across the age spectrum. So I treat 1-month-olds with torticollis and developmental delay, and I treat 92-year-olds with gait and balance dysfunction, and really everything that you can say that's orthopedic related in between. But my specialty focus is in pelvic health. And I do have a lot of patients within the perinatal space, so pregnancy to postpartum. So I treat a lot of birthing individuals as well. So within that scope, there's a lot of unique, kind of diagnoses or common themes that I tend to see in the perinatal space, which is very underdiagnosed, underspoken about, taboo topics. So I love talking about those with people because everybody knows about frozen shoulders and ankle sprains. And that's kind of like back pain and neck pain. Like, sure, like we know what that is. And when we feel it, we go get help. But a lot of times people don't get help for things that are, related to the urinary system or related to the reproductive system or related to their GI tract. And so I think those are like, when it comes to pelvic health, we talk a lot about bowel, bladder, and sexual dysfunction. And so my focus in that is really my passion and my work is to help people understand that when you have good quality of life, it's really when all systems in your body are in check. And especially in this world and this is kind of like my 2 cents is, we've had a very male dominated medical system for a very long time. And so when women enter the system, I still feel that female physicians, surgeons, OBGYNs still don't fully understand the spectrum of what their patients are undergoing. And then particularly for people of color. We know the significance and a lot of the statistics out there on maternal mortality for Black and brown mothers and in this country, and we know that a lot of the work needs to focus on the care that we provide as professionals and looking at these birthing individuals, and then also even more in a focused lens on women in particular who are not getting the treatments that they need because it's kind of brushed off like you'll be fine. They don't really treat C-sections as major abdominal surgery. I mean, you get an ACL tear and you have prescribed like months of physical therapy. And, a C-section is just, you're cutting through layers of tissue and organs and fat and muscle layers in the most central part of your body. And then you're expected to return to work and return to function and carry your baby and feed your baby and also do the chores. Sure. And so I think that those are the themes that I talk about in my work and my practice, which maybe people don't know too much about, or maybe are just kind of understanding in the spectrum. So I can keep talking, but I'll stop there.
That's just so great. We definitely need to talk about it more because we're not heard. And that's therefore, to be able to encourage women to take maternity leave and get paid for it, we have to voice our concerns, right? America is one of the few countries that doesn't even pay for maternity leave. It's so sad, right? And it's interesting that you brought up C-section cutting through, the uterus. How do you incorporate, what are some common symptoms that someone would need to think about, or they're like, oh, wow, I should actually go get pelvic floor PT. I should really think about my pelvic health. What are some of those symptoms?
Yeah, so it runs the gamut, but I would say for a C-section in particular, I think the biggest myth is, oh, I got a C-section, my pelvic floor is fine. I did not have a vaginal delivery, so everything should be okay, right? But that's not always the case because it's really the 10 months that the mother is, or the birthing parent is carrying their child, the postural shifts, the orthopedic shifts that we know that happen, that's very physics related, also very mechanical shifts that happen to the spine and to the body, and the muscular changes that happen from changing the position with your center of mass being put more forward over your base of support. So all of those things change your pelvic floor. And for those of you guys who are listening who are like, what is pelvic floor? I don't know what that is. It's basically a set of soft tissue structures that are located in your perineum, which is basically in between your pubic bone and your tailbone and in between the two sides of your sit bones. So you can think about everything that you sit on if you were to ride a bike, or if you were to sit on a horse or on a saddle, it's the same area. And it's consisting of muscles, there are ligaments, there are glands, there are nerves, there are blood vessels, fascia, connective tissue, and everything that I'm describing, you have everywhere else. Your shoulder joint has those same things, your knee joint has those same things, your ankle joint has those same things. It's the same kind of structures, it's just accessed differently. So if you have, for example, somebody who has a limp from their ankle sprain, And if they're wearing crutches or if they're on a boot, a lot of times they'll experience lower back pain. And why is that? Because they're kind of off balance, right? Their gait changes. And so we take a look at that and from a holistic perspective. So with a C-section, you're not foolproof of a lot of pelvic floor dysfunction because during pregnancy, there are those shifts in your body that can shift the way that your muscles are structured and can also just generally change your body. So when we specifically say C-section, though, what I find in my practice the most is lower abdominal discomfort, and lack of ability to access and engage their deep core muscles in their front of their abdomen. So a lot of people will complain of pain and soreness and tightness at the scar site. And that's because when there's a scar, there's a natural healing process. And when there's a process, there can be scar tissue adhesions, which are basically restrictions in the connective tissue which might be natural, but which can be disruptive to movement and function. So one of the things we really need to focus on in that area is mobility. So that can be done through direct scar tissue manipulation, visceral mobilization around the organs, and or general full body stretches that are specific and catered to what that person's problem is. And so these can't be kind of blanket exercises because I can find two people who had the same kind of birth story, but their bodies can look totally different. And so I couldn't just tell everyone to do, this is a blanket stretch, hold it for 30 seconds. That's why it's important to do a full musculoskeletal orthopedic exam in that initial evaluation, understand how their spine is moving, how their pelvic girdle is functioned, how is their sacroiliac joint, how is their coccyx functioning, and then assess the muscles of the pelvic floor and the deep abdominal muscles. And from that information, we can tailor very specific exercises and stretches to both build mobility and build a stability needed in those deep abdominal muscles and the pelvic floor muscles, so people can feel like they can tolerate all of these new activities, which literally happen overnight. You have no baby, and then you have a baby in your arms, and now all of a sudden you have to feed, rock, put to sleep, pick up and off, on and off the floor. You have like a million things that I call the baby related tasks overnight. And so in order to be able to sustain that and then potentially have to go back to an employer who's telling you have no maternity leave, there's like a lot of societal components to this. And so I think that addressing the quality of life problem here is key to helping people get back to function. And of course, there's also the urinary dysfunction. So urgency, frequency, urinary incontinence, and then constipation or, tailbone pain or hemorrhoids or episiotomy, kind of related things that can also happen as well.
That's good. I like the mobility and stability and building up the core and also stretching and making sure that it's nice and soft, right? So it just depends. It's important to go find someone who can do this evaluation if you have any of these issues, whether it's a C-section or even normal birth. So we talked about C-section, but normal birth, you also go through that 10th month pregnancy and changes, right? So your pelvic floor muscles also change. I know because I recently gave birth. So thank you. And so I was really trying to really concentrate on my own pelvic floor. So I did a lot of squats when I was pregnant, but really and plies, and to really build up the floor, because even if you're pregnant, you can prepare for the birth, right? When you build it up while pregnant, because I think it actually helped me give birth much easier.
That's great.
Pushes. Maybe she came out in 5 to 6 pushes. It was really, really, really good for a first time birth, right? So I think definitely thinking and being cognizant of that pelvic floor is important all throughout a woman's life.
Exactly.
All right. So what do you think people should do if their doctor says, hey, maybe, you need to go get surgery, but they can always optimize first, right? By going to physical therapy and even before and after. What are some of those steps that you would recommend?
Sure. So, I mean, I know we're kind of stepping away from just the pregnancy realm here and in general orthopedics. I definitely think that anybody who's listening, if you have an injury that this is the first time that you're speaking up to your doctor about, and there are very few exceptions to this, but if the first thing that the doctor says is that you need to get a surgery for this, please go the other direction. because most of the time when it comes to orthopedic related chronic pain, I'm not talking about if you got into a car accident or if you had your appendix burst. I'm not talking about those kinds of things, but I'm talking about the general, my neck hurts, my knee hurts, my something hurts, my back hurts, and they scan you and they say, oh, look, you're broken, you need surgery. Go the other direction, because there are so many things that you can do conservatively that are going to help you. Firstly, we got to figure out why that thing happened in the first place, especially if it's not an acute injury. I'm talking about for things that have built up over time and are more like on a chronic basis. It's not from an accident or an incident or a fall. But if there's some pain that's been lingering, that's been getting worse and worse for you, and you go to the doctor, you need to figure out why that's happening. Most of the time, it's because of the way we're holding ourselves in space and the way that we're moving in that space. And so we have to figure out what those root causes are, and that's hard work. And that's what a physical therapist is going to do, is change those behavioral patterns, strengthen the muscles that need to get stronger, relax and lengthen the muscles that need to get longer and more flexible, and actually get you into long-term health that's more sustainable. Surgeries are often a one-time thing, and guess what? You're going to have to go to PT after anyways. Any major surgery, they're going to tell you have to go to physical therapy. So might as well go to physical therapy at first. And hopefully you get a good, there are good physical therapists and there's bad physical therapists. I'm not going to say that physical therapy as a profession is perfect. I know for a fact, I can't say that, it's going to be great, but I would say find somebody who's vetted in that particular area of the body and understands also how to treat you holistically within that system. And then go and do your therapy and do your homework. Anything that's done to you is not long lasting. Anything that you do is more long lasting. Manual therapy, adjustments, mobilizations, massage, anything that's like cupping, anything that are injections, anything that's lotion, ultrasound, or electrodes, or all of these like little things are not going to be your long lasting healing factors. The long lasting healing factor is how you move your body. And that is going to only change with awareness, number one, in what you're doing, and actually be willing to change. I can tell you the number of times that I have a patient who I'm an in-home physical therapist. So I see people in their environments all the time. And the number of times I will see somebody and be like, let me see how your desk setup is. And they're like, I don't have one. I sit on my bed. And it's like, well, we got to change this. And then 3 weeks goes by and nothing has changed. And I've told them exactly what they need to do, and it's compliance. And so if you're not willing to change the way that you hold your body in space, we're at a loss. So physical therapy, really, honestly, I'm biased, obviously, because it's my profession, but we do manipulations, we do mobilizations, we do massage. In a lot of states, we do dry needling, which is basically acupuncture. But in a completely different sense, not on meridians or not through Chinese medicine, but through motor neurons, alpha motor neurons, and understanding muscle spasms. But we do everything. We do the exercise therapy, we do the education, we do the pain neuroscience, we do it all. And so getting a good physical therapist who really understands the entire musculoskeletal system, understands your needs and your goals is key. Surgery, injections, all those things have a time and place. There are tons of people that I send to surgery or I send to injections. I'm not saying that those are terrible things. They're definitely have a time and place. They're life-saving in so many cases. But I'm talking about the very specific case of the orthopedic pain that somebody feels. They go to the doctor for the first time or maybe the second time without doing any conservative treatment, and they're prescribed surgery. That's when I'm like, this is a problem with America's medical industry and insurance and all that crap that, that's another topic.
That's so true. So definitely red flags go up if, hey, your doctor says you really need surgery, but you haven't gone through PT. That's always the first step, before you go through surgery, I would say, unless it's, yes, like you said, the appendix and things like that. So I love that whole person kind of rundown that PTs go through. How are you guys kind of different from the personal trainers and the chiropractors, just so that people can understand what PTs do?
Yeah, so kind of like I mentioned, so physical therapists go through typically, there's different tracks, of course, of training, but the track that I went through and the one that I think that the majority of people, at least when I graduated, went through is 4 years of undergraduate degree with basically pre-med. There's only a few classes that are different for pre-PT and pre-med. And then you do 3 years of a doctorate in physical therapy. So this includes cadaver dissection and tons of courses that you take that are very, very medically oriented. You have lab work, you do rotations, and the training once you graduate is that you have a DPT or a doctorate in physical therapy. So, and in many states, we also have direct access. So, and actually, I think most or all states at this point, you have some level of direct access, which means you don't have to go see a physician or a doctor in order to get a script for physical therapy. You can go straight to a physical therapist for an initial evaluation, and they can screen you for red flags or screen you to do a full systems review and say, are you a candidate for physical therapy or not? If you're not, they will refer you to the correct provider. For example, I had a patient come into me actually like 3 months ago, and she came in with a nerve pain at the top of her foot. And I did my full evaluation of her lower spine and everything that I needed to do to understand what's going on. And I suspected that this is not a spine related issue or a sciatica sort of a thing. This looks like it's a Morton's neuroma. And so I sent her to go get an ultrasound, and lo and behold, that's what it was. It's basically a nerve bundle at the top of the foot and between a few of the toes. And so we understand what it is. So physical therapists have full training to understand, red flags like deep vein thrombosis or cardiac issues and other things like that. We understand if the person who's coming through the door sees us, and then we screen them and we evaluate them as a holistic person. We do a full body evaluation, whether you're coming into me for neck pain or whether you're coming into me for ankle pain. I'm taking a look at your posture, your overall general mobility, your general strength, and then I'm assessing all of the pieces that I need to understand and devise a plan of care. And because we're medical providers, we work with documentation. We write SOAP notes, the subjective, the objective, the plan, the assessment and the plan, and we create medical documentation. We put you through a plan of care based on all of our tools that we can use to help you with treatment. We communicate with our patients, and then that can involve, things like manual therapy, things like exercise therapy, neuromuscular reeducational, functional training and functional assessment, and then a whole host of modalities. So having said that, personal trainers work just with the exercise component of this. Personal trainers are not, unless you have other certifications, personal trainers are not licensed to put their hands on you and stretch your body. They're not licensed to use your body and move your body. They're allowed to instruct you on how to do exercises. And of course, there's different certifications and different levels. But physical therapists are doing an assessment and doing treatment and doing plan of care for either prevention or rehabilitation. If that person is going through injuries or going through pain, the personal trainer should refer to physical therapy for rehabilitation and is not licensed to care or treat for that person, for example. And then if you take a look at, for example, massage therapists, they are not prescribing exercises. They are not doing medical documentation in the same capacity. Their role is just with the manual massage. And sure, tons of people can go and say, I have an anchor pain here, and we're just working through it. Physical therapists are going to look at, why is that hurting you? What's the reason that that's hurting you? We're doing an investigation to figure out and create long-lasting health, and not just doing things to you, but understanding when we go back to whatever you do yourself is more long-lasting. So we focus on that. And what is the functional training and the postural training and the, activities that they're doing in their life that we need to modify in certain ways, so you actually don't feel those pains in order to have to go get weekly massages in the first place. I mean, don't get me wrong. I like weekly massages, but that's not the point. Our plan is, when you walk in, we're making a discharge plan for you. You're not in physical therapy forever. If I have it my way, as soon as the patient walks in, I'm figuring out how many sessions can I get them better, in the least amount of time and maximize the value out of it. So that's just a little bit of, yeah.
I do like trying to get to the root cause, because that's what functional medicine is, trying to get to the root cause, and then giving you the tools, right? That's the tools that you yourself can go home, do those exercises, rather than, like you said, having massage every week. That's just great to know what is structurally the problem and then fix that, right? So
exactly,
fixing the why, that's great.
Mm-hmm.
All right. And you said you're a dancer. But you see a lot of probably athletes or dancers. And how do you use that and to do a movement screen when you're evaluating your patients?
Great question. I'd say that with dancers and athletes, they're very similar in the sense that they need to get back to stage, get back to the field, get back to the court, get back to sport, get back to play. That's their goal, right? It's their body is their livelihood. And usually there's a lot of, urgency to get better quickly, especially the pressure from parents and coaches and trainers and directors. So when I'm doing the screening, it's very similar to how I would do everybody else's, but I'm really targeting on healing time and making sure that I'm really sticking to maximizing recovery in the shortest time that I can safely for the patient, and making sure that everybody's on board with that plan. So the assessment, the treatment, the diagnosis, all of that really stays largely the same. There's really not much more. There are some specific, objective measures or tools that I'll use, but just like I would with a patient whose goal is to get out of bed pain-free, I look at those motions and be like, what do we need to do to make sure that these motions don't hurt you? It's the same way with a dancer or an athlete. If I know that a dancer says during these particular movements is where my pain gets exacerbated, I look at ways that we can either modify that or we can rehabilitate that to very specific, exercises and specific rehabilitation techniques to make sure that that's pain-free or as pain-free as possible. Same thing with an athlete. If they're telling me that, these are the particular, it's always cutting. Like I had a soccer player once who told me it's just with the tackle that hurts, with the playing soccer. Like there are just very specific kind of ways that his ankle moved, that's what exacerbated his pain. And so by that, I know the structures that are, involved and what's going on and why it hurts him. And so I target those very specifically to make sure that we're maximizing it so that if and when he gets into a position, it's a lot of reactive stuff in athletics and a lot of proactive stuff in performing arts because it's planned ahead of time usually. Mm-hmm. So based on what I see, a lot of athletes, I do a lot of plyometrics and a lot of reactive balance and things like that. And with dancers, we're really focusing on how do we create stability through a movement and make sure that when they're doing that movement, they're not going off balance or, their joints are moving in a particular way that they feel more stabilized and supported.
Yeah, that's great, Dr. Sneha. So it's been great having you on our show as we talked about pelvic floor PT and also how to get a second opinion if you needed to really get PT before surgery or even after surgery. And we are thankful that you came here. And so any last words, or where can people find you if they wanted to see where you're at?
Sure. Yeah. You can see me on my website, www.snehaphysicaltherapy.com. So SNEHA physicaltherapy.com. And that's my handle on social media as well. So on Facebook, it's Sneha Physical Therapy. And my handle on Instagram is at Sneha Physical Therapy as well, which is where I hang out with all the people, share videos and tips and advice. So
that's right. And you have your own podcast too, right?
That's right. I also have a podcast. It's called Fit as a Fiddle. And so we share similar topics on health and wellness. So Dr. Lam, maybe you should come on my show as well. Nice.
For sure. We'll do that. Awesome. So thank you for being on our show. If you've liked and if you really learned a lot, definitely share it and subscribe to our channel. And we'll see you next week.